evening, everyone. Thanks for the opportunity. So my topic is upfront cytoreductive nephrectomy for metastatic renal cell carcinoma treated with immune checkpoint inhibitors or targeted therapy. An observational study from the International Metastatic Renal Cell Carcinoma Database Consortium. So the purpose of this study was to evaluate the relationship between upfront cytoreductive nephrectomy and the clinical outcomes in the setting of metastatic RCC treated with immune checkpoint inhibitors or targeted therapy. So before going into the results of this study, so I'll just go back through some background of this study, the purpose of this study. So we all know these are the actually interleukin time of era of RCT, the SOC trial, EORTC trial. So they evaluated the role of cytoreductive nephrectomy and they found that there is a definite survival advantage of doing cytoreductive nephrectomy with interleukin 1 or interferon alpha. Then we got TKIs. So there were a lot of retrospective studies and they all proved that definitely, even with the TKIs also like sorafenib, sunitinib and other TKIs, there is a definite advantage in terms of overall survival with cytoreductive nephrectomy. But these were retrospective studies, not prospective studies. So a lot of actually theories has been given behind that, why this cytoreductive nephrectomy is improving the overall survival if we are adding along with the TKIs. So first theory was because the whole tumor is basically induces a lot of cytokines storm in the body, cytokine production, which inhibit the T cell functions. So when you take out the kidney, you just decrease the burden of tumor in the body and they basically increase the T cell functions. So they increase the immunity of body. So they take care of metastatic site also. And there are few case reports also where it has been seen that by doing cytoreductive nephrectomy, the pulmonary metastasis, solitary or just few metastases, they regressed by their own without getting any systemic treatment. So they supported this kind of theory. Another, the large tumor also harbors a pool of heterogeneous tumor clones, and nephrectomy has been shown to reduce the circulating VEGF also. But with the this trial, Carmina trial actually, so this was the first published randomized trial which compared, actually it was a non-inferiority trial, but it compared the Sutent versus cytoreductive nephrectomy followed by the sunitinib. And it showed that there is no advantage of cytoreductive nephrectomy if it is being combined with the sunitinib. Because it has been said that the sunitinib, it is a very potent TKI, so probably it is providing all alone the survival advantage. So there is no need of doing cytoreductive nephrectomy in these patients. But on subgroup analysis, it was found that if patient is having a good risk score and if even it is an intermediate risk along with only one risk factor, there is definite advantage of doing cytoreductive nephrectomy even if patients are being given sunitinib. Then we got the immune checkpoint inhibitors and we saw the paradigm shift in the management of the RCC, metastatic RCC, and we saw a huge incremental increase in overall survival and progression-free survival in our patient with the use of either IO-IO combination or IO-TKI combination. Now, if you see with the Pembro and Linva, we are even this overall survival initially they were not statistically reached actually. So all these patients live very longer, even in sunitinib group, because all these patients who failed on sunitinib, they got all these therapies, even their survival increased in another arm. So with the time, because now there is a perception in the clinician mind that now we are having a very good, very potent systemic therapy. So probably there is no need of doing cytoreductive nephrectomy because whatever survival advantage we can get only with the use of combination of all these therapies, systemic therapies. So subsequently what happened with the trials actually, the use of cytoreductive nephrectomy has decreased. Initially, all these trials, they used cytoreductive nephrectomy in more than 90% of their population, but that decreased up to 70% in recent trials with the use of cytoreductive nephrectomy, you can see. But the question is, as I have told that this is a very heterogeneous, basically clonal population in the primary RCC as well as at the metastatic site. So this is a basically mutation phylogeny of RCC. For an example, this is the primary tumor. So it has multiple mutations. All the mutation started with VHL and PBRM. And again, when the accumulation happens with other mutations, they accumulate the metastatic potential. So the primary tumor has mutation in the PTEN gene and in SED D2 gene along with the mutation in VHL and PBRM in every clone, whereas the metastatic cells, when they got the mutation in STD along with the TP53, they accumulated the metastatic potential. And those cells which were in the liver as a metastatic, they had only mutation in the TP53 and SETD2. So what happens in the whole body? If you see, there is a difference in the mutation. So if you give systemic therapy to all these patients, there is a basically partial response we see. So metastatic side, they do have a much better response compared to the primary tumor. And it happened in every trial. So if you'll see, or as a monotherapy of ICI or targeted therapy. Whereas at the metastatic side, we see response in the more than 90% of the patient. So now the question is there any definite role of cytoreductive nephrectomy in immune checkpoint era therapy also? Because we have used CRN in the targeted therapy in our patient. So this study actually tried to include all the patients from the consortium. So finally, they excluded a lot of patients. They finally included almost 4,500 patients for the final analysis. They divided their population, the patients, into whether they got ICI or the targeted therapy. And finally, they divided these group into two subgroups, whether they got the cytoreductive nephrectomy or not cytoreductive nephrectomy. So in immune checkpoint group, almost 54% of the patient, they had already got the cytoreductive nephrectomy. Whereas in targeted therapy, almost 55% of the population underwent targeted therapy already. So this gives you a just general idea of cytoreductive nephrectomy also, like how much we are using in our patient right now, despite of all these randomized trial like Carmina trial results. So this is just a demographic profile of the patient. So if you'll see very carefully, the patient who had very good Karnofsky performance score, those who had a favorable and intermediate risk group, and clear cell histopathology without any sarcomatoid feature, and limited number of metastases, they all had a very high chance of getting cytoreductive nephrectomy. So these are the results. So those patients who were on immune checkpoint inhibitor, if they underwent cytoreductive nephrectomy prior to getting ICI, there is a definite advantage in terms of survival with hazard ratio of 0.6. Same with the use of TKI also. If they underwent cytoreductive nephrectomy before getting TKIs, there is a definite advantage in terms of overall survival with hazard ratio of 0.72. And from the multivariable logistic regression, it was found that the patient, if they are older, more than 65 years of age group, if there was presence of any bone, brain or liver metastasis, less likely to get the cytoreductive nephrectomy. So conclusion is always use cytoreductive nephrectomy in good or intermediate risk patients, whether they are getting ICI or TKI, it doesn't matter, because it has been now seen with this study that there is a definite survival advantage of using cytoreductive nephrectomy, whether you are using ICI or targeted therapy. Thank you.